I would like to start out by saying that I have been incredibly fortunate to have spent my career in Seattle at the University of Washington with collaborators both here at the University of Washington and at Fred Hutch. As an epidemiologist, my role is pretty much one of coordination, that is coordinating, working with people in clinical sciences, laboratory-based sciences, biostatistics, and essentially bringing together multidisciplinary projects. And that's something that it's very easy to do here at the University of Washington, or certainly with the STD group. It's been phenomenal, and it's not so easy at other institutions. And I must give credit to mentors and collaborators who have worked with me over the years: King Holmes, Jim Hughes, Noel Weiss, Nancy Kiviat in particular in pathology has been a major collaborator, Jane Kuipers, Jinghua Feng, and then also several predoctoral and postdoctoral students who certainly provide the foundation for this work. And I've also had a long collaboration with Denise Galloway and Jody Carter over at Fred Hutch that's been enormously fruitful. And finally, I must mention Katherine Jansen. Katherine Jansen approached me in the early 1990s. She had just been made head of this new program within Merck, and that was to develop the Hpv vaccine. Merck had licensed the material from CSL, a company in Australia, to develop this vaccine. And initially there wasn't that much excitement, but as Katherine got into it and realized the potential, she approached me about heading up the epidemiology and clinical designs of their studies. So I have worked with the program for several years now. And I would say that in my mind, Katherine Jansen is the person who really should be given the most credit for the development of a safe and highly effective Hpv vaccine. She's now at Wyeth. She loves developing new vaccines, and she had better opportunities there. So with that, just a bit of background on cervical cancer and HPV. Cervical cancer is a common cancer worldwide. It's estimated there have been about 500,000 cases globally each year for the last few years, with about 250,000 deaths. Importantly, about 80% of these cancers occur in developing countries. And that's because in developing countries, you don't have access to routine Pap testing. In countries like the US, where you have Pap testing, we've actually seen dramatic declines in rates of cervical cancer. Another important point is that cervical cancer, relative to other cancers, actually kills at an early age, a median of about 57 years versus 72 years for all other cancers, which indicates that it actually is a major cause of productive life years lost. About HPV, we recognize over 100 different human papillomaviruses types, and these viruses have evolved to actually be very efficient and have a nice lifestyle in that they infect the largest organ in the body, the skin. And over time, as they evolve with humans, they differentiated, and essentially you have different types infecting different areas of the skin, and there are those types that preferentially infect the genital tract, and there's about 40 types that preferentially infect the genital tract, and I'll be talking more about those later. Another important point to be made is papillomavirus infections stay confined to the epithelium. The virus does not circulate in the blood. In terms of the papillomavirus genome, it's a circular double-stranded DNA molecule, and there's two genes that are important to point out. There is or three genes I should say. The E6 and E7 genes are the genes that are responsible for proteins that interact with human tumor suppressor proteins and actually inactivate those activities. So E6 complexes with P53 and E7 protein complexes with RB. And this is actually the mechanism through which carcinogenesis occurs when it's related to oncogenic HPV types. The other gene that's important is the L1 gene, and that is the gene that codes for the protein which forms the basis of the capsid of the virus and also serves as the component that is used in these vaccines. A bit about HPV epidemiology. I use lifetime risk estimates for HPV-related endpoints because HPV does happen to be an infection that can have consequences at many points during the lifespan. Importantly, genital HPV infections are incredibly common. At least 1 in 2 adults, probably more close to 80% of adults will be infected with 1 or more genital HPV type during their lifetime. Genital warts, some people think they're relatively rare. There's new data that suggests that actually about 1 in 10 perhaps of all adults will have had an episode of genital warts. The firmer data suggests it's more like 1 in 15. Abnormal pap smears, again in countries where you have routine pap testing, and women who undergo routine pap testing, meaning every year or even every other year, know that they stand a good chance of getting an abnormal pap. That's because genital HPV infection is so common, and the changes that are seen on cervical cytology that are classified as dysplasias are actually changes caused by HPV. So abnormal pap findings are actually relatively common, at least 1 in 3 women during their lifetime. Cervical cancer in regions where you have pap testing, less than 1 in 100 women during their lifetime, but in regions without routine pap testing, more like about 1 in 25 women. Other anogenital cancers, not only is cervix cancer caused by HPV, but you also have vaginal, vulvar, penile, and anal cancers, as well as a portion of head and neck cancers. Other anogenital cancers are rare, except for anal cancer in men who have sex with men. And anal cancer in men who have sex with men is actually estimated to be very common. These are pretty crude estimates, but it makes sense because within the anal canal there is a squamocolumnar junction, just as there is in the uterine cervix, and this is a site of infection by high-risk HPV types and a site where the cancers develop. And finally, head and neck cancers, about 20% or less than 1 in 400 adults will have an HPV-related head or neck cancer, primarily oral or oropharyngeal. So in terms of the types of HPV that cause cervical cancer as well as other anogenital tract cancers, the most common cancer-related HPV type is Hpv 16. And as shown in this figure, it accounts for roughly 50% of cervical cancers worldwide, with Hpv 18 in the what appears to be more of a magenta color, accounting for somewhere between 10 and 20% of cervical cancers worldwide. Virtually all cervical cancers are HPV related. Adenocarcinomas as well as squamous carcinomas. So a vaccine that targets Hpv 16 and 18 should eventually eliminate about 70% of cervical cancers. As you can see with this list of HPV types, if you go from 16 to 18, the next logical types in terms of their distribution in cancers worldwide would be Hpv 45, 31, 33, 58, and 52. If you included virus-like particles for all 8 of these types, you'd provide protection for about 87% of cervical cancers. There's a number of other types that account for 1, 2%. So if we need to keep increasing the number of virus-like particles to increase the protective effect of the vaccine, to get to 100% really will involve a large number of virus-like particles. This is assuming no cross-protection, and I'll talk about that a little bit later. Okay, cervical cancer screening. The goal of cervical cancer screening, I know those of us who have been getting PAPs all the time, we sort of think, is it to get an abnormal PAP, or what we're told when we have an abnormal PAP that we had a positive test for cancer or an abnormal test that indicates cancer. But really, most abnormal PAP findings are HPV infection or actually false positives. And I think it's important always to keep focused, particularly as we move forward with vaccines and PAP screening, because we're not going to get rid of PAP screening in the foreseeable future, or some form of cervical cancer screening, that we keep our eye on the fact that we do cervical cancer screening to basically bring on early diagnosis and treatment of precancerous cervical lesions, those being CIN grade 3, including carcinoma in situ, adenocarcinoma in situ, and microinvasive cervical cancer, all asymptomatic lesions that are highly treatable and bring about long-term survival when they're detected early and treated early. Treatment of CIN2 is also part of the program, and that's largely because CIN2 increasingly appears to be a histologically ambiguous presentation of either a CIN1, which is probably productive HPV infection in most cases, or CIN3. So it's sort of our hedge category. So treatment of CIN2 also is important. So as far as those Pap smear findings, in the 15 to 20 years I've been in the field of HPV and cervical cancer, I think I've seen 3 revisions to what you should call Pap smear findings. It's as if they come up with these new names. I'm not sure that it's given any better specificity to the classification system or any more accuracy in the diagnosis, but we do have the most recent set of Pap classifications within normal limits. My favorite, atypical cells of undetermined significance, which really does mean the cytopathologist really doesn't know what these cells are from. And people often are of the opinion that you get an ascus and then you get a low grade and then you get a high grade, and there's this continuum of events, but that really isn't the case. An ascus Pap really does mean we don't know what's here, and it's just as likely to be from a high grade lesion as it is from a low grade lesion. Atypical glandular cells, we have our low-grade squamous intraepithelial lesions, high-grade squamous intraepithelial lesions, and invasive cancers. So new recommendations have incorporated HPV DNA testing, which I think is, the data has convincingly shown is a worthwhile endeavor. And the way that it's introduced for all women is what's called reflex HPV DNA testing in women with ascus. So you don't test everyone. It's women who have this equivocal, we don't know what it is, Pap ascus. And numerous modeling studies have shown this approach to be cost effective. For women, it's helpful because it doesn't mean they get put in this follow-up. The other thing about Pap screening is you get screened if you've got an ascus. In the past, and often in many clinics today, still you're asked to come in 4 to 6 months, and you're put on this cycle of continuing to come in and left in this limbo land. The beauty of having an HPV test at the time of an ascus is, boom, right away, if you're HPV positive, you're scheduled for colpo and biopsy. If you're not HPV positive, you can go back into routine screening. However, even with the HPV test in combination with an ascus Pap, we're still only about 50% sensitive for CIN 2 to 3. So the sensitivity of a Pap is poor, and that's been known for quite a while now. The reason a Pap works and does a good job and has brought about a 75% reduction in incidence of cervical cancer is because women get Paps so often. You need to go in repeatedly, and with a series of repeated Paps, eventually if you have a high-grade lesion or cancer, it will be detected. More recently, the FDA approved primary adjunctive screening, including Pap and HPV for everyone, but only in women 30 years of age or greater. And this is because in women who are in their late teens, early 20s, women who would meet guidelines for screening, that is being within 3 years of initiation of sexual activity or age 21, there is just a huge burden of HPV infection that has nothing to do with precancerous lesions. And it just would refer, if you were to do both Pap and HPV testing on women in their 20s, you would be referring basically anywhere from 1 in 3 or 1 in 4 women to a colpo biopsy. Way too expensive and not worthwhile. This type of screening regime, however, has been shown to have high sensitivity for detecting high-grade lesions and cancer, over 90% in most studies, some studies even 100%, and a high negative predictive value, which is also nice for women over the age of 30. If both of your tests, your Pap and your HPV test, come back negative, you can be reassured because of the high negative predictive value that it is very unlikely that you have a precursor lesion, much more so than if you had only had the Pap. However, because of the added expense, both the Pap and the HPV test, the only one that is currently licensed is the Hybrid Capture 2. It's the only FDA-approved test, are relatively costly. models have suggested that this is a cost-effective measure only if you can reassure women if they're double negatives to not come back every year, but to come back, for example, every 3 years or even every 5 years. So the Hybrid Capture 2 test is the only available test. It's not a type-specific test. It actually is a test that's formatted to detect 1 of 15 high-risk HPV types, 1 or more of 15 high-risk HPV types. Even though it's not type-specific, it has been a good screening test when used either in reflex testing or primary adjunctive screening. Now, one of the reasons it's important to consider HPV testing is illustrated in this pair of slides from a woman who participated in a multi-center randomized controlled trial that we participated in here in Seattle. And it basically just shows you what happened on day 1. This woman, we had cervograms, which are colposcopic images. They were purely for keeping images of what was seen. We were not using them for diagnostic purposes. On day 1, she had a liquid-based or thin prep Pap test that was interpreted as reactive, which essentially is within normal limits. Her Hybrid Capture 2 test was positive. She normally would have gone back into routine Pap follow-up, which probably would have meant she would have been seen again in 1 to 2 years, depending on how busy she got with her life. But because she was in the trial, she came back in every 6 months, and at month 18, her thin prep Pap again showed only a low-grade SIL lesion. However, the Hybrid Capture 2 was positive, and she also had a biopsy that day because it was a grossly visible lesion, which it turned out to be an invasive squamous cell carcinoma. This is a rare presentation. However, it's again a reason why HPV testing does, in my mind, play a role moving forward with improved screening, and also a reason why, if we can get a vaccine, it will be wonderful because we essentially can completely eliminate these types of scenarios. So what about moving forward with cervical cancer screening now that we're heading into the era of HPV vaccination? Well, as I mentioned before, screening guidelines are not likely to change in the foreseeable future. However, as HPV vaccination becomes more widespread, we can anticipate seeing a decreased prevalence of precancerous cervical lesions and ultimately cervical cancer. And what this will result in is fewer women going in for colposcopy, biopsy, treatments, and more intensive monitoring for a prior high-grade lesion. The impact on the prevalence of abnormal Pap will probably be pretty minimal with just the 4 or the 2 HPV types targeted, and that's because within the age group that is getting abnormal Paps, the 18 to about 30-year-olds, HPV infections are so common that not only do people have one HPV type, they often have multiple, and each of those types can be causing cellular changes that are picked up on a Pap smear. Another important change that will happen is that the negative predictive value of both Pap and HPV DNA testing will increase. And what we hope, what that means is there will be fewer falsely negative findings. And what that, again, should give more reassurance to women that if they do have a negative Pap and HPV test, they really probably don't have anything there, and they can wait to have their next screening in another 3 to 5 years. At the same time, the positive predictive value of both Pap and HPV DNA testing will decrease, which will mean that essentially among women who have abnormal Paps, a smaller percentage will actually have an underlying lesion. And it's one of the reasons why, moving forward, it still is important to come up with better cervical cancer screening tests. And a lot of effort has gone into this. And I think it is time to look at, people have said, well, the Pap works, why replace the Pap? Well, yes, it works, but I think we can come up with something better. And certainly looking for HPV DNA is one strategy. The problem with HPV DNA, though, even from just high-risk types, is that it is a non-specific test. So then we talk about primary screening, looking for specific HPV types. And there's some work going on doing that, particularly looking at typing for HPV 16. If in a year you still have 16, then going for a colposcopy and biopsy. Which leads us into looking at persistence. You'll read a lot in the literature about HPV persistence and the importance of persistent HPV in developing high-grade lesions. In my mind, anyone who is persistent falls into one of two categories. They're persistent either because they have an underlying lesion, because that's what's producing the virus, or they're persistent because they're having reactivations over time. And that's work a woman named Laura Securo, who's actually a doctoral student in the molecular and cell biology program, worked with me on a project looking at long-term persistence, and lo and behold, it turns out that about at least 15%, if not more, women will reactivate out to 10 years with HPV types and really not have any lesions. They probably have a small focus of infection. They produce some virus, the immune system sees it, it blocks the infection from getting any more serious, and it no longer becomes detectable. And I think throughout our lifespan, there's more evidence to suggest that this is more of a natural course of these infections. There's work going on looking at E6 and E7 mRNA tests to detect the RNA, with the presumption that if you have mRNA from the oncogenes that are actually important for causing cancer, that you would have a more accurate test. So far, the data, it's just a little bit, I'm not convinced by the data that we're there with this particular test yet. The PreTect HPV Proofer, I think, targets about 5 different high-risk HPV types. There have been groups looking at gene expression analysis, whether something is upregulated or downregulated. Again, the data suggests that you're going to see certain patterns more in cancer than not in cancer, but really that in-between category, that CIN3 that we really want to detect with screening, it's somewhat of a mixed story. Similarly for chromosomal gains and losses. There is a final marker that's been looked at, and that's P16INK4A, which is a cyclin-dependent kinase inhibitor. And it's a protein that in cells that are immortalized or infected with oncogenic HPV types, it turns out that this protein accumulates because the cell regulatory machinery gets interrupted. It's actually the E7 that is complexing with RB to release E2F to stimulate cell cycling, rather than, I believe it's CDK4. And so what happens, the cycling gets mixed up in HPV infected cells, and you just accumulate P16 protein. And we actually have an ongoing screening study now looking at this. The beauty of this, if it works out, is that it can be an ELISA format. It could actually be a point-of-care test where a woman could come in, you could do a cervical sample, put it on a slide and look at it. If it lights up, she would need to go in for a colposcopy and biopsy. But it's too early yet to know whether this is going to work out. It looks great on histology sections. Whether it will translate to a screening test is still under investigation. So this work is going on as we're in the process of looking at HPV vaccines. And before I talk about the results for the HPV vaccine, just to put in context the other vaccines that we as a society have made a decision to implement, and I think it's true that vaccines really are the most important, in my mind, public health measure of the last century, and have made a major impact on the health of this nation and populations worldwide. So before, what this slide is showing the annual morbidity prior to the introduction of the vaccine, and then 2003 morbidity. And these are data from the CDC. And what I've done is put together somewhat of a parallel slide showing the potential annual impact of HPV 6, 11, 16, 18 vaccines in the US. And what's shown is the estimated annual morbidity prior to the introduction of the HPV vaccines. For cervical cancer, vulvovaginal, penile, and anal cancers, head and neck cancers, recurrent respiratory papillomatosis, which is caused when HPV 6 or 11 is transmitted from the mother to the infant during the birthing process. The infant develops papillomas. It's a highly morbid condition because these papillomas need to have repeated surgical treatment. CIN1, CIN2, 3, AIS, and genital warts. And then once we get to widespread vaccine coverage, how much of this morbidity could be prevented. And if you look at invasive, the cancers alone, you get up to about 15,000 cases a year, which if you look back, for example, at paralytic polio, it is a favorable comparison in terms of a vaccine that really, I think, deserves societal support. And then you also have these other conditions which, while they're not going to kill you per se, they actually are incredibly costly and cause a fair amount of anxiety and medical intervention. So why was a HPV vaccine feasible? Well, an important point is that the papillomavirus genome is really stable, and the genital types are highly conserved worldwide. So as I showed in that slide of cancers, you also find the prevalence of HPV types in populations throughout the world is relatively similar. There are some changes that may become important as we look at increasing the valency of the vaccines, but by and large, 16, 18 are the two most common types in cancers, and 16 and 52 tend to be the more prevalent cancer-related types. Work done, in particular, Denise Galloway's lab here in Seattle was collaborating with us on our cohort studies showing that the virus-like particles of the L1 protein are highly immunogenic. That is that the immune response with even natural infection, effectively, once the virus is recognized, it appears to disappear. It becomes no longer detectable. There's a portion of women who clearly retain copies of the virus, but basically it's a delay in the immune response seeing the virus, but once it does, for the vast majority of individuals, they no longer have detectable viral DNA. And perhaps one of the most important features for an HPV vaccine is that there were very successful animal models. And I don't mean taking human papillomavirus and putting it in mice or human papillomavirus and putting it in dogs, but I mean looking at species-specific infection and showing that the virus-like particles would indeed prevent infection and the disease. And my favorite model is the model in the dogs, where a group at Georgetown demonstrated that by using canine oral papillomavirus virus-like particles, if you injected dogs with these intramuscularly and then challenged them with canine oral papillomavirus, you prevented the oral warts that were so common. And this is an epidemiologist view of how this vaccine is made. It's pretty simplistic, but just to walk you through it, you start out with a papillomavirus, and within the virus, the double-stranded circular DNA, the L1 gene, is removed and inserted into a plasmid, which is then inserted into the nucleus of the cell. And as the cell undergoes transcription and translation of the DNA, so does the L1 gene, forming capsid proteins, which then are brought back into the nucleus and reassemble into empty virus-like particles, which to me is actually magical that this happens. And then each of the companies use a different adjuvant. These empty virus-like particles serve the basis of the vaccine, and then one company uses alum as an adjuvant and the other ASO4, which is a new adjuvant. And this injected intramuscularly is what stimulates the immune response or production of antibodies, which is important for blocking infection. So this is a slide just showing you what I'm going to present is the data from the phase 2B data, which are essentially proof of concept data for the Merck vaccine program and the GlaxoSmithKline vaccine program. And just to orient you to the way I think as an epidemiologist, in these designs you have your target population and then you randomize people. And for a prophylactic vaccine, this is to be given to susceptible individuals. You need to remove people who are already infected. But this can be done either before enrolling the patient or the individuals or during the analysis. People are randomized to receive vaccine or no vaccine, and then they're followed for the endpoint of interest. So in terms of the two studies, the bivalent vaccine is the GSK vaccine, and the quadrivalent is the Merck vaccine. Both studies involved target populations for their primary analyses of susceptible females. For the bivalent vaccine, they were interested in females who were susceptible to acquiring HPV 16 or 18, and for the quadrivalent, it was HPV 6, 11, 16, or 18. These are from the primary for the primary analyses. However, an important design feature in terms of when you interpret the data from these trials, it's important to keep this in mind. In the GlaxoSmithKline trials, they did pre-screening, and in the Merck trials, they did not. Essentially, what you see in the first few lines is, in terms of the enrolled population, they were very similar. Healthy women from Brazil, Canada, Europe, ages about 15 to 25 years, fewer than 6 or fewer than 5 sex partners, and no verbal report of an abnormal Pap. In the GSK studies, they actually did a pre-screening visit, so no woman with HPV DNA to high risk, any high risk type, was included in the trial, or if they had serum antibodies to HPV 16 or 18, or if they also had a pre-screening Pap if they'd had an abnormal Pap before study entry. So they removed a number of people who already had HPV infections. So keeping that in mind, these are the primary data from these phase 2b studies, and what is important to note is that regardless of these differences in designs, and that's what I spend big chunk of my time thinking about is study designs, and lo and behold, it really doesn't make that much difference, particularly when you have such a terrific vaccine, that if you look at the Merck trial, overall the vaccine was 94% effective in preventing persistent HPV 6, 11, 16, or 18 infection. And for GSK, their primary endpoint of interest was persistent HPV 16 or 18 infection that could be detected over 12 months. Again, 94% protective. Both vaccines are administered in 3 doses, 0, 2, or 0, 1, and 6 months. And both, from what I can tell, and I'll show you some more data, appear to have similar levels of efficacy and also immunogenicity. These are the immunogenicity data, or the antibody titer data from the Merck program, looking at the total HPV 6, 11, 16, and 18 IgG antibody titers from both that were generated from both the vaccine and when you have natural infection. And what you can see is out to 55 months with the vaccine, the antibodies persist, and essentially for HPV 6, 11, 16, and 18, for all 4 types, you see high-level antibody titers, much higher than what you see with natural infection, which is the black line below for each of these. Similarly, for the GSK vaccine, the bivalent 16-18 vaccine, again, you see persistence of high-level antibody in those who are vaccinated, the blue being HPV 16, this paler blue being natural infection antibody titers, and similarly for HPV 18. So these vaccines are producing antibody titers that appear to be sustained for the vast majority of individuals over time. Other findings, the vaccines were generally safe and well tolerated, really not significant differences between the 2 trials. Most common problems were pain, redness, swelling at the site of injection, more often in the vaccinees than the placebo recipients. The VLP vaccine cannot cause HPV infection. It only contains one viral protein, L1, and L1 is not a human carcinogen. Other work has shown that these L1 VLPs appear to elicit both B-cell and T-cell responses. The few vaccine failures, and there have been few that could be failures, have not been related to having low antibody titers. And it's not clear, certainly there will be and have been undoubtedly vaccine failures, but the other thing about testing for HPV, it's a very low level infection. And even if you try to screen out people who are infected at baseline, it's likely that you're going to miss some who have already been infected, particularly if they're between the ages of 16 and 25, which is what was included in these trials. And finally, protection appears to be mediated via transudation of antibodies through the basement membrane. For a while there, one of the issues that was stopping other companies from getting into this field of development of HPV vaccines was the idea that you needed to have secretory antibody flowing over the surface of the epithelium, and that just doesn't appear to be the case, and it makes sense because the papillomavirus is infecting a cell at the basement membrane. We don't know if it's a stem cell, a metaplastic cell, a basal cell, but it's a cell at the basement membrane. So the way that you're going to protect and block infection is to have transudate coming up through the basement membrane. So currently, the international phase 3 programs, GSK's vaccine Cervix, it's the bivalent 16-18 vaccine, and they have phase 3 trials going on where they're doing a randomized trial of Cervix versus Havarex, their hepatitis A vaccine. And they have over 30,000 women participating, either from different places around the world or specifically within Costa Rica, which is an arm that NCI is managing. They are also doing a trial in what we call the old ladies, which is women who are 26 to 55 years of age. This is clearly an important target population for the vaccine manufacturers because these women, as opposed to the younger women, actually often have insurance and have money. Whether it's going to be a worthwhile population to vaccinate is uncertain at this time. GSK filed in Europe in June, I believe, or sometime this summer, and their trials will continue through 2010. The Merck vaccine, the Gardasil vaccine, is still in phase 3 trials, although an interim analysis provided the data that were sufficient to take to the FDA and get regulatory approval at the end, or in mid-2006. Currently, the vaccine is licensed in multiple countries throughout the world. Having said that, their major phase 3 trial should be ending in a couple months. They also have an old lady trial of women who are 24 to 45 years of age. And in contrast to GSK, they are viewing their vaccine to target both boys and girls, not just girls. So they have a trial of young men. So I know quite a bit more about the Merck program because I've been participating in it, but I will say that as far as I can tell, in terms of the safety and efficacy and immunogenicity of the GSK or the Merck vaccines, they look to be pretty similar for the types that they target. And I'll present now some of the data from the phase 3 Quadrivalent program. This is a program that involved about 20,000 women from different countries around the world. An age range of 15 to 26, average age of sexual debut of 17. And overall, there were 73% of the enrolled women who were naive to all 4 HPV vaccine types. So you can see already within this age range, you have about 27% of women who were positive for one or more of the targeted HPV types. Having said that, it was less than 1% of women who were positive for all 4 types. So there theoretically would be some benefit in vaccinating in this age range. And I'll show you some of the efficacy data for that. So in terms of looking at the susceptible population, so this is looking at development of HPV 16-18 related CIN2-3 or adenocarcinoma in situ in women who are naive. They're susceptible for HPV 16 or 18 at enrollment. Follow-up is only 2 years, 25 months, and already, as you can see in the first line of this table, there were 81 cases of HPV 16-18 related CIN2-3 or AIS in the placebo recipients and only 1 in the vaccine group for an overall vaccine efficacy of 99%. I chose these data because these include data from all women who were vaccinated who were susceptible. Often you see data that says 100% and it's the people who are completely naive who got all 3 doses of vaccine exactly when they should have. This is actually everyone who got at least 1 dose of vaccine and starting counting cases from 1 month post-dose 1. High efficacy even after just 1 injection. That doesn't mean you only need 1 injection, but it means that right away the antibody titers that are being raised undoubtedly have some protective effect, and I'll talk about that a little bit later. All of the endpoints in this study were based on a blinded panel review by expert pathologists and an adjudicated diagnosis. In terms of the vulvovaginal findings, again, the vaccine was highly effective in a susceptible population, being women who were naive, no DNA, no antibody at enrollment for HPV 6, 11, 16, and or 18. Again, high-level efficacy, 95%. When you look at the data on women who got at least 1 injection with endpoints starting to accrue 1 month after the first dose of vaccine. So effective for both genital warts and other minor lesions, the vulva and vagina, as well as the precancers of the vagina and vulva, VIN2-3 and vein 2-3, although there were only 9 events of the latter. So now we look at a general population sample. So looking at the Merck data, not excluding anyone. This is the true intention to treat analysis for North America. And what you see here is, so this is not excluding anyone who has prevalent infection, prevalent disease at baseline. Vaccine efficacy of 68%. So what you're seeing is already once you get into a sexually active population, which basically all of these women were, already you have women who have developed lesions that will not be prevented or cleared by this vaccine. It's a prophylactic vaccine. And it again points out the need to get this vaccine into boys and girls before they initiate sexual activity. So summary of the findings, as I mentioned, protection appears to start early during the course of the vaccination series. And we know this because we see so many more cases of Cin 2-3 in the placebo recipients than in the vaccinees when we start counting cases from after the first dose of vaccine. Having said that, probably it appears that 3 doses are important, not for immediate protection, but for developing the type of immune response, developing those memory cells that are going to give you long-term protection. So probably 3 doses are important. However, when those doses are given does not appear to be important. In these trials, although women were told to use reliable contraception and not to get pregnant, there was a fair number of women who got pregnant. And we did not. We did pregnancy tests before we vaccinated, and if somebody had a positive pregnancy test, they were not vaccinated, and they were put on a delayed schedule. There were also other reasons. As you can imagine, the age range 15 to 25 is a very transient group of women. We were actually paying to fly people back to Seattle for their visits, and sometimes you couldn't schedule those correctly. And regardless, those previous slides that I showed with 99% efficacy or 95% efficacy were based on women getting injections at any point in time within the first, well, actually basically at any point in time, but most of that was occurring within the first 12 months. So there appears to be flexibility around the dosing of vaccine. Another important point is infection with one HPV type did not impact efficacy or safety for the other HPV types. So the beauty of the Merck design is because they had prevalent disease in the population, they could look at, okay, if you give this vaccine to somebody who had HPV 16, would their response to HPV 18 be different, or would their response to HPV 6 be different, or would their safety profile be different? And there really was no indication that that was occurring. Another point was that in a previous trial, and then also in all of the Merck trials, because women who were infected were enrolled, we have indication that there is an animistic response. The data on efficacy now is only out to about 5 years post dose 3. And we really need efficacy out longer than that. However, what these data suggest by showing that there is an animistic response is if we need a booster, it looks like it would be effective, because individuals who were previously infected, when they're injected, their titers are significantly higher than those women who had not been previously infected. And similarly, when you give a booster dose out at month 24, you again see a titer that's much higher. Future data. What are we expecting to see in the not too distant future? Well, first of all, data that will tell us whether or not rates of incident HPV infection and Cin 2-3 warrant vaccination of older women. I have no doubt that the vaccine will be effective in older women, but is there enough disease to really warrant using this vaccine? If you're preventing 1 case versus 0, you get 100% efficacy, but is that really worthwhile? We'll also have information on prevention of HPV infection among young men, including MSM. There's some indication that this vaccine provides some post-infection prophylaxis, meaning that there were women who were HPV DNA positive for 16, for example, at day 1. They were vaccinated, and there was a level of protection among that group. If they had antibody on board already, there was no protection. It looks like this is early infection, and the reason this might be important is that it suggests that it could be used, for example, in rape clinics to prevent establishment of infection. But we need certainly more data in this area. Merck is working with the pediatric HIV cohort study group, and actually I believe have a fully enrolled group of adolescents with HIV to look at safety and immunogenicity in that cohort. They will not be looking at efficacy, at least initially. I'm not sure about longer term plans. Finally, this issue of replacement, whether or not if you get rid of HPV 16 and 18, will you see replacement of oncogenic types causing new lesions? So essentially you don't have that much impact on the burden of disease. From what I can tell, I don't think this will happen, because at this point we have women who are infected on 1 visit with up to 7 types. The disease that's caused by HPV really only takes 1 cell. It's not as if the disease is caused by destroying multiple cells or stimulating an immune response that causes a lot of problem. And I think that this will not be an issue, but certainly it warrants monitoring going forward. Duration of protection is clearly very important. Will we need a booster? And finally, as we move forward with effectiveness trials and studies in populations to determine the effect of herd immunity. Okay, challenges to implementing vaccine programs. The 3 C's, cost, consensus, and coverage. The vaccine is not inexpensive in my mind. $360 in the private sector for the 3-dose series, $300 to public health. The Advisory Committee on Immunization Practices just negotiated a price of $96 a dose for the Vaccine for Children program. This vaccine, the quadrivalent Gardasil vaccine, is included in the Vaccine for Children program. Consensus, a big hurdle. And I think this comes down to the fact that parents don't like to think that their kids are sexually active. Actually, I think it's even worse for kids. They don't like to think their parents are sexually active. But there's a huge denial in society about the fact that adolescents are sexually active. I mean, about half of 16, 17-year-olds have already initiated sexual activity. And this is a reason you have got to get this vaccine at an earlier age, and the target age is 11 to 12-year-olds. And then there's also this lack of knowledge of HPV and the link with anogenital cancers. And finally, we get into the issue of vaccine availability, recommendations, and cost-effective distribution. There's been a lot of talk about school mandates, and Matt Golden, who heads up the STD program and is terrific, I think has a great idea, and that's to get rid of the term school mandates and call it routine school vaccination, because mandates have an implication that can be scary. So we're calling it routine school administration. And you have your opposition, it can be viewed as coercive, and then you have anti-vaccine groups. And it can be costly, although it is truly the most cost-effective way to administer this vaccine. As has been shown with hepatitis B vaccine, once you put in place routine school administration, you basically triple the levels of coverage with hepatitis B vaccine. So it's really the best strategy for getting population-based coverage with these vaccines. And also in most states, I think all states have a parental opt-out option, which means that parents can choose not to have their children vaccinated. And the reasons can be either for medical exemptions, personal exemptions, or religious exemptions. And what's important to keep in mind with these opt-out clauses, it's not an onerous activity on the part of the parents. There's essentially just a box they need to check and minimal information to be provided if they choose not to have their children vaccinated. It's one of the reasons I think it allows for parents to feel comfortable about school-age vaccination programs, because there is an understanding that if they really don't want their child vaccinated, they don't have to have their child vaccinated. So moving on now to recommendations for how the quadrivalent or the Gardasil vaccine should be administered. Acog, or the American College of Obstetrics and Gynecology, has come out with recommendations. And their recommendations, which are similar to the Advisory Committee on Immunization Practices, is that females 9 to 26 years of age should be vaccinated regardless of sexual activity. The vaccine is only approved for use in females at this point. And in this country, in Australia, they made the leap to also approve it for boys and girls, but not in this country or in any other country that I know of yet. Other ACOG recommendations include the fact that Pap screening should continue, whatever the clinician was doing for a Pap screening guideline, that they should continue with that guideline. Also, it's clear that this vaccine will be more effective if administered before sexual activity, because these infections are so common. It's important to get the vaccine on board before boys and girls become exposed to the different HPV types with the onset of sexual activity. It's also important that women who have already initiated sexual activity be counseled as to the fact that the vaccine may be less beneficial to them because they may have already been infected by one of the types targeted by the vaccine. And finally, with additional recommendations, it's important that women know that the vaccine is not a treatment for current HPV infection or genital warts, and that pregnant women should not be vaccinated. Although the vaccine looks safe, there are data on congenital anomalies that if you cut the data a certain way, there were 5 congenital anomalies occurring in the vaccine group and 0 in the placebo recipients. Those congenital anomalies were actually looked at by an expert here, Michael Cunningham. All the data was sent to him, and other congenital anomalies as well. And essentially, it's a constellation of very diverse congenital anomalies, and the rate is consistent with what you would see in a normal population. Having said that, there still is, and the circular that is distributed with the vaccine also says it should not be given to pregnant women, and it should not until there's more data on pregnancy outcomes. However, women who are breastfeeding can receive the vaccine. And then I would just like to highlight an issue of vaccine that is a supplement that includes several excellent chapters on HPV in relation to cervical cancer and screening, and the development of the vaccines and the public health issues moving forward, both in developed and developing countries. Thank you.